Good afternoon. Welcome back, everybody. It's a pleasure to be here. I am indeed, I'm just checking the buttons here. Yep. I'm David Thaler from Boston. I was a member, well, still am a member of the steering committee for the RESPECT trial as well as the Amulet trial, as my disclosures here. There are many things that we can learn from the trials that we've done so far, especially in the PFO business, and how they may apply to other device trials aimed at stroke prevention, which are really stroke trials. It's surprising how often these are discussed in cardiology meetings and less so in neurology meetings, and less neurology input than I think there should be in what is essentially a stroke trial. But these are just some of the topics that I thought I'd highlight today. First of all, when is an episode of something a stroke, and what caused it? When something is a history of stroke and it's an important inclusion criterion, who should be evaluating that? Inclusion criterion for a clinical trial. Outcome ascertainment, I think, is critical, and we'll review a little bit of how perhaps that should be done. And finally, the outcome definitions, I think, have an impact on how we evaluate the studies. So first of all, if something comes in and looks like a stroke, and it is a stroke, then that's not very complicated. If someone has a right hemiparesis and aphasia and a gaze deviation to the left, you don't need a neurologist to tell you that that's a left MCA syndrome. That's an easy one. But there are some things that come in looking like a stroke that are in fact not strokes, and those are the stroke mimics. Stroke mimics, this is a fairly sophisticated audience, so I'm not going to go into this in great detail, but of course, all sorts of things can look like strokes. Migraines and seizures, hypoglycemia can have an apparently focal deficit on presentation. These are the things that neurologists in particular are trained at uncovering and making sure that something that looks like a stroke is in fact a stroke rather than one of these mimics. But then there are things that come in, don't look exactly like a stroke is meant to look like, and some of those things are not a stroke. That too is not too complicated. If somebody's encephalopathic with a urine infection, you don't need a neurologist to tell you that that's not a stroke. But there are sometimes that there's an atypical presentation when in fact it is a stroke, and those are referred to now as stroke chameleons. And one study looking at the presentations and how they were initially interpreted. So in this study, altered mental status was the initial diagnosis for what in fact turned out to be a stroke. That's probably a lot of aphasic patients and so forth that weren't adequately evaluated. Syncope was the mistaken diagnosis, infections, and various other things. So stroke chameleons are important. Now, these things, the green ones, I think anybody can figure out. You don't need neurologists to figure out when something doesn't look like a stroke and it isn't, or it does look like a stroke and it is. But these are the circumstances where I think neurology can be particularly helpful at evaluating patients. Just very briefly, I want to highlight a patient that I saw fairly recently. I'm the PFO guy in Boston. This was a woman who was from Rhode Island. She was young. She had a branched retinal artery occlusion, so a small infarct in her left retina. It had occurred 3 months before I saw her. It occurred 16 hours after an airplane flight. She was seen by a local neurologist and a local cardiologist. She was found to have a PFO, and she came up to talk to the PFO guy about whether she should be closed or not. This was a picture I took of her, and you should be able to see that she has a little bit of ptosis on her left side, and I asked her about it, and nobody else had before this, but she had noticed it herself. This is a picture she took of herself at the time, shortly after this branch retinal artery occlusion had occurred. It's hard to appreciate, but her pupils really are exactly the same size. I wanted to see whether in the dark one was bigger or smaller, and I actually took her into the bathroom chaperoned by a female medical student. I closed the door. My clinic room is very bright, so I couldn't make it dark enough, but we got into a completely dark place, and her pupils were really exactly the same size. So I couldn't convince myself that she had a Horner syndrome, which would have suggested a different diagnosis. I did have available to me one floor below some aproclonidine drops, which I put into her eyes, which is an alpha-2 agonist. And what you can see now is her ptosis resolved completely after about 30 minutes, and she's hypersensitive. The left pupil is now bigger than the right, which indicates that she had a resolved Horner syndrome, and her diagnosis, of course, was nothing to do with her PFO. And so the PFO guy told her to forget it, and we treated her for her ICA dissection that she had had. This is the kind of complication that can occur in people who are evaluating strokes and not paying attention to the mechanism of the stroke, which I think is important when you're deciding how to include patients into clinical trials. Stroke is an observation. It's not a diagnosis. This is the mantra that I instill into my residents. I'm not going to belabor this. Of course, there are many mechanisms of cerebral ischemia. We can subcategorize them into these three major categories. Embolism can be from various sources. This is a very rare explanation in spite of the so-called hemodynamically significant stenoses. They really are rarely hemodynamic. And I think it's important to keep this in mind. It's important to keep these in mind. This is partly why stroke neurologists still need jobs, because these take a little bit more work to uncover. And I think it's important when considering who to include in a clinical trial that patients have been evaluated appropriately. One meaning of cryptogenic is when you've been completely evaluated and there is no cause. But of course, the other historical meaning of cryptogenic is when you've been completely evaluated and there are too many causes. Somebody with atrial fibrillation and a 90% ipsilateral carotid stenosis. You can see this penguin is beaked in the back, and there are a lot of suspects that could be considered. So it's important to keep not only the patients who need an explanation, but it's hard sometimes to evaluate those who have too many explanations. So in the Amulet trial, this is inclusion criterion 3, you can see there's a CHAD score of greater than or equal to 2, or CHADS VASC of greater than 3, which largely people end up getting because of a prior history of TIA or stroke. Do we want the cardiologists, and for those cardiologists in the room, I apologize, but do you yourselves want to be the one evaluating whether a patient who comes to you with a history of stroke or TIA actually had a stroke or TIA, or shouldn't that be left up to somebody else? So I think in the evaluation of the inclusion of patients in clinical trials, especially if a prior history of stroke or TIA is in part relevant, that a neurologist should be involved in evaluating that. So I apologize. This is a Mac to PC translation problem, but this is a booklet that I've suggested be given out to every cardiologist, which is that not every dizzy spell is a TIA. That's Dizzy Gillespie, of course. And I think that would be useful. So how about outcome ascertainment? All these studies rely on evaluating patients who have episodes and seeing whether there are more episodes in one group than another. But how do we decide who has an episode? What tools do we use? And what is the NIH stroke scale score meant to be used for? And what is it sometimes implied that it can be used for? This is an old study now, 1996. This was about endarterectomy trials, but it showed that if studies included a neurologist as one of the assessors for the trial, or if a neurologist was included as an author, the incidence rates of stroke or death went up significantly. And these are the power of having a neurologist be part of the evaluation of outcomes of patients in clinical trials. Either we're causing a lot of strokes, or we're the ones who are better able at evaluating them and uncovering them. So I think the outcome ascertainment should not be done by somebody walking by the end of the room and saying, "How you doing?" You need somehow to carefully evaluate whether a patient is likely to have had an outcome event or not. This questionnaire for verifying stroke-free status was initially created for the ACAS trial. It's an I know you can't read that, but it's published. It's an 8-question questionnaire that just requires a yes or no answer from a patient. Has a doctor told you since I last saw you that you've had a new stroke or TIA? Have you had any sudden episodes of this or that? And any yes answers on this questionnaire requires evaluation by a neurologist to determine whether or not it's actually a stroke. This is an incredibly sensitive tool, an incredibly non-specific tool. So it can't be used by itself, but it's a very good screening tool for patients who are coming in for clinical trials to determine whether or not an outcome event was likely to have occurred. And this is what was seen. These are the first 25 outcomes in the RESPECT trial, PFO closure versus medical therapy trial. And you can see that a third or a half of the outcome events, just those first 25, were uncovered by this screening tool, not because an adverse event had occurred and somebody ended up going to the hospital and this study found out about it. So the screening tool in the RESPECT trial was useful for discovering that some patients, a third or a half of them, had had an event that required the screening tool, then referral to a neurologist, then adjudication by the clinical events committee. What the NIH stroke scale is not is a diagnostic tool. I think for the neurologist in the audience, this is not news. But to cardiologists, sometimes I hear, yeah, well, can you do the stroke scale and decide if they've had a stroke or not? The NIH stroke scale is only intended to be applied to patients who have already had a stroke, to measure with a stylized neurological exam to give a score of how severe the stroke is in a neurological basis, not a functional impact basis. And it is useful for prognostication as well, but it is not a diagnostic tool. And so I think people who are qualified to use the stroke scale and who apply the stroke scale appropriately can help to quantify strokes that have occurred, but it would be a mistake, I think, to have, for example, a nurse practitioner do a stroke scale on an annual basis in patients in clinical trials to decide if that's the patient that had a recurrent stroke or not. So how about the outcome definition? Because stroke is not a disease and it's a whole bunch of heterogeneous disorders, it always feels uncomfortable to me to have all stroke as the outcome for stroke prevention trials when you're using targeted therapies. It's a little bit like doing a mastectomy trial for breast cancer and using all cancers that emerge in the follow-up period as the outcome. It would be silly to include colon cancers and pancreas cancers in a mastectomy trial. And similarly, for PFO closure, for left atrial occlusion, it would be silly to include somebody with a small vessel stroke or a dissection or a neurosurgical misadventure complication as the outcome for a trial which is a very targeted specific therapy. We used in the RESPECT trial the ASCOD classification to subcategorize all of the recurrent strokes that occurred in the RESPECT trial, keeping in mind that PFO closure can only be expected to prevent PFO-related recurrences. And if somebody now has lupus or some other intracranial problem that caused the stroke, it would be hard to evaluate the efficacy of the specific treatment that we're testing if we're including all these confounding stroke mechanisms, just like including colon cancer as an outcome measure for a mastectomy trial. It would seem silly. So we did this in the RESPECT trial, and this is just the first 42 recurrent strokes, and there were a few more in the data that we presented at TCT, but you can see stroke of known mechanism was occurring in around a third of all of the patients, and there were the distribution was different in the device versus the medical management patient, but the point is here that there were strokes of determined mechanism that were clouding our ability to interpret the PFO closure specific effect. Just as an aside, people were concerned about atrial fibrillation in device patients. There were 4 recurrent strokes in the entire trial that were now associated to emergent atrial fibrillation that occurred during the course of the trial. All 3 of the medically managed patients, cardioembolic strokes, were due to AFib, and there was 1 in the device group. So AFib did emerge in this population, which wasn't too surprising, but it did not seem to be disproportionate in the PFO closure patients. So this is the extended follow-up data. These are not the data that I presented at TCT last November. But just to make the point about the cryptogenic, the still cryptogenic strokes, the strokes which now had a known mechanism are clouding these curves, which was not significant after 5 years or so of follow-up. But each one of these dots, they're yellow on my computer, they come up green here, but each one of these green dots represents a stroke of known cause, could not have been prevented by PFO closure. And when you remove those, then you get a strongly significant effect on the outcome stroke. So preventing cryptogenic strokes, or still cryptogenic strokes, is what I think PFO closure is useful for. And I think left atrial occlusion devices may have the same problem, because there will be recurrent strokes which have nothing to do with atrial fibrillation, have everything to do with carotid disease or dissections or intracranial atherosclerosis or something else. And I think it's important to determine what the outcome strokes were. I'm going to skip over this one in the interest of time. So it may never come to this. This is the vision of cardiologists and neurologists. This is now legal in the United States. But this is the RESPECT Trial Steering Committee, so we've gotten close. So this is me and Jeff Saver from UCLA, who's a vascular neurologist, and John Carroll and Richard Smalling, who are two cardiologists. So at least in the clinical trial realm, we're all very friendly. And I think this can continue out, if you like, in the real world. The wild type of neurologists and cardiologists, I think, can continue to be friends. And I think they should be. So stroke is a heterogeneous disorder with mimics and chameleons. Close collaboration between cardiology and vascular neurology, I think, needs to continue. And I would strongly suggest consider objective and validated screening tools rather than an untrained non-neurologist walking by somebody's room and asking if they had an outcome event. Have a very low threshold for referring potential outcome events to the clinical events committee, and then consider adjudicating the mechanism of outcome strokes, because targeted treatments like PFO closure and left atrial occlusion can't prevent all recurrences. They can only prevent, if they're actually working, the types of strokes that we think they can. Thank you very much.